Greetings everyone and welcome to phase 2 of our study, exploring the protective benefit of gastrointestinal bleeding prophylaxis in patients initiated on dual antiplatelet therapy or DAPT after an acute coronary syndrome. This study was conducted by Dr. Sandra Wijekularatne, Dr. Nzube, Ekpunobi, myself, Dr. Jaraad, Dr. Fatima, Sylla, Dr. Anisha, and Dr. Robert Gu. So a little bit about the background of this study. Oftentimes, the prophylaxis against stress ulcers and GI bleeding is inappropriately prescribed in the hospital inpatient setting. There are specific indications, however, for GI prophylaxis, and these typically include patients who are at a higher risk of a bleed while in the inpatient setting. For example, patients who are on long-term steroid therapy, patients who are mechanically ventilated for more than 48 hours, patients who have suffered CNS or burn trauma, have a history of GI bleed within the past year, or patients who have been admitted in the ICU for more than a week are oftentimes treated and prescribed a GI prophylaxis. However, despite the clear guidelines and guidance to the intervention, this therapy is often treated as a general prophylactic treatment similar to VTE prophylaxis. Unfortunately, GI bleeding prophylaxis has risks. For example, using a proton pump inhibitor to achieve a GI bleed increases the risk of hospital-acquired pneumonia, osteoporosis, and C. diff infection. Given the risks associated with starting a GI prophylaxis, its indications are somewhat limited. However, we do think it is worth exploring whether expanding these indications to include patients at a high risk of bleeding due to recent initiation of an antiplatelet or anticoagulation therapy is beneficial. So in specific, this quality improvement project will study the efficacy of GI bleed prophylaxis for patients who are on DAPT or dual antiplatelet therapy following an ACS or acute coronary syndrome. Our null hypothesis is that there will be a superior net benefit to the patients started on GI bleed prophylaxis with DAPT compared to those without GI bleed prophylaxis. In addition, we expect a lower incidence of GI bleed in patients who are started on dual antiplatelet therapy with GI bleed prophylaxis, such as H2 blocker or proton pump inhibitor. So the methods that were involved in this study explored the primary outcome measure via retrospective cohort analysis. The primary outcome measures included those on DAPT following an ACS who suffered a significant GI bleed event, which required an inpatient management within 6 months of an ACS diagnosis while on a GI bleed prophylaxis, contrasted against those without prophylaxis. The study selected random patients who were admitted to DMC Huron Valley Hospital who suffered an ACS within the past 6 months. The cohorts included patients placed on DAPT following ACS without proton pump inhibitor or H2 blocker therapy, and patients placed on a DAPT following ACS who were given the proton pump therapy or comparable H2 blocker. And we had to exclude patients who suffered an ACS and expired within 12 months of the event. So what did our results show? Our results showed that we had a list of 140 random patients who were admitted between January 1st, 2021 and December 31st, 2022, and who had a 6-month lead-out time for potential bleeding events. Out of the 140 patients who did suffer an ACS, 117 or 84% were placed on DAPT. And amongst that group, 73 patients or 62.4% received moderate to high dose pantoprazole, omeprazole, or famotidine as a GI bleed prophylaxis. While of that group, 44 patients or 37.6% did not. So a majority of the patients of the ACS group who were placed on DAPT did receive GI bleed prophylaxis. And again, among the group receiving the GI bleed prophylaxis, 8.2% of those patients suffered a GI bleed within 6 months, while 9.09% in the group without prophylaxis suffered a GI bleed in the same time frame. So we can see from the results that there wasn't really a significant benefit of starting a GI bleed prophylaxis in patients with DAPT, as we can see that 8.2 and 9.09 isn't a significant difference. So initially we set up this project to explore whether there is a benefit to extending the indications for GI bleed prophylaxis towards those placed on DAPT following ACS to hopefully reduce catastrophic GI bleeds. However, this study proved that there is no net benefit in starting a GI bleed prophylaxis in patients initiated on DAPT following an ACS. The ACS cohort that suffered a GI bleed on prophylaxis is about 1% less than those who suffered a GI bleed without prophylaxis. However, our sample size is too small for this to be a meaningful risk reduction, and it would only be possible to calculate a reliable NNT by expanding the scale and scope of our studies in the terms of size and time observed. Thank you all for listening and participating in this study, and I wish you all a good day. Thanks.